Welcome to Healthcare Logic for Growth, the weekly show where we talk life sciences and healthcare in general, things like clinical operations, research, commercial strategy, market analytics, and what it takes for anyone in healthcare to grow in a sustainable way. I'm Eric Marr, your host, the founder of Life Science Logic and a current Life Science Association board member. So whether you're building a biotech, running a rural hospital, leading a home health agency, or shaping healthcare policy, this show is for you. Hello, everyone, and welcome back. We're on episode 2 of our 10-part series for the RHTP, or Rural Health Transformation Program. Today's episode title, RHTP Money versus Rural Hospital Reality. Why the math is still questionable. As always, I'll share a few opinions and insights regarding the RHTP, but everyone should come to their own determinations and embrace the directions that make the most sense for you. Everybody's environment is a little bit different. We just hope this helps you with your upcoming decisions and kind of provide a framework of things to consider while coming to those decisions. In our first episode, we chatted about the RHTP and why it represents a significant moment for rural health. As a reminder, the federal program provides $50 billion nationally over 5 years, and Texas is expected to receive approximately $281 million annually from 2026 through 2030 via its Rural Texas Strong plan. By the way, I kind of mentioned it, but much of our discussion applies to rural health hospitals across the country, but every state's rural health environment is just a little bit different. So really look into that if you get the chance. We're focused primarily on Texas today because they have the largest number of rural health hospitals that are facing closure, about 50 of them. But if you want more insight into that, check out last week's podcast. We go in a little bit deeper onto those kinds of things. The uncomfortable truth is this. Rural hospitals in Texas are struggling from deep financial deficits and RHTP dollars landing on top of that financial strain rather than fully resolving it. Rural hospitals constantly battle closure risk, thin operating margins, debt, limited reserves, workforce shortages, payer roadblocks, and, of course, Medicaid cuts. So while RHTP creates meaningful opportunity, it is not a blank check. It is not a hospital bailout, and it does not erase the fundamental economic pressures that rural hospitals face every single day. In this episode, we'll cover why RHTP funding is thin relative to the losses and risks rural hospitals face, why the underlying economics of rural healthcare still matter, what does all of this mean for vendors that sell products and services to rural hospitals, and a practical go-forward strategy for both hospital and vendors if it makes sense to either or both. But let's start with the financial reality. We call it the structural deficit. When we use the phrase structural deficit, we're not talking about one bad year, one failed project, or one difficult payer contract. We're talking about a long-term pattern. Rural hospitals often operate with lower margins than urban facilities. Even in relatively stable years, they may have little financial room for error, right? Research has consistently found that rural hospitals tend to have lower operating margins and higher financial vulnerability than urban hospitals. Probably not a surprise to you, but it's worth stating and recognizing every now and then. For many hospitals, a small change can become a major event. Let me share some examples of that. Physician leaves the community. Labor costs rise. Emergency department volumes increase, but reimbursement does not. A local employer reduces benefits or closes. A payer contract changes. The hospital must invest in cybersecurity, EHR upgrades, or aging infrastructure. That's just to name a few. But any of those events can strain a hospital's operating budget. Several realities are especially important in rural Texas. First, Rural communities rely heavily on public insurance programs. Medicare and Medicaid are essential to rural hospitals, but reimbursement from those programs often does not fully cover the actual cost of care. When a hospital serves a high percentage of Medicaid and uninsured patients, it can face a persistent reimbursement gap. Second, uncompensated care remains a major concern. When patients do not have coverage or cannot afford their portion of care, the hospital still provides treatment, but the organization may never receive full payment. That creates bad debt, charity care, and ongoing pressure related to cash flow. Third, many rural hospitals operate with limited reserves. They may have aging facilities, delayed capital projects, outdated technology, and very small teams trying to manage clinical operations, finance, IT, compliance, recruitment, and community outreach all at the same time. That's a heavy load to bear. And fourth, debt does not disappear just because a new grant opportunity arrives. That's an important one to remember. Research on rural hospital financial distress shows that low margins, high debt, low liquidity, and limited patient volume are all associated with a greater risk of closure. So before RHTP funding ever reaches a hospital or community, many rural providers are already managing a very difficult financial situation. And then, of course, we have the Medicaid issue. Federal policy changes are expected to reduce Medicaid spending substantially over time. KFF estimates that the legislation creating the Rural Health Transformation Program will reduce federal Medicaid spending by hundreds of billions of dollars overall, including an estimated $137 billion in rural areas over 10 years. The RHTP provides, $50 billion nationally over 5 years? And that is meaningful money, but it also illustrates the gap that we're talking about. RHTP is a major investment. It is. But it's smaller and more temporary than the broader financial pressures rural providers will face year in and year out. This is why it's important to understand RHTP as transformation funding, not permanent operating relief. So when we think of big numbers and thin dollars, Texas is expected to receive about $281 million annually, as I mentioned, through the RHTP program from fiscal year 2026 through 2030. At first glance, that sounds like a major inflow of rural healthcare funding. And again, it is. But the context matters. Texas has a very large rural population, a large geography, many rural hospitals, critical access facilities, rural health clinics, behavioral health needs, workforce shortages, and significant access challenges. When KFF, as a reminder, the Kaiser Family Foundation, calculated first-year RHTP awards on a per rural resident basis, Texas received approximately $66 per rural resident, the lowest among, states receiving first-year awards. That's extremely low. That doesn't mean Texas is receiving an insignificant total award, of course, but it means the need is spread across a very large rural population and a very large number of communities. There is another key limitation. Let me tell you what it is. RHTP funds don't simply flow into hospital operating accounts. The program is designed to support state-led transformation efforts across multiple areas, including prevention and chronic disease management, workforce development, technology and infrastructure, innovative care delivery models, behavioral health and substance abuse services, alternative payment approaches, community-based care and access initiatives. And there's more, but that's just a list of the ones that they're faced with day in and day out and seems to be at the headlines. CMS also limits the share of funds that states can use for direct provider payments and capital expenditures. Direct provider payments are limited no more than 15% of the state's RHTP funding, and capital or infrastructure expenditures are limited to 20%. So if Texas receives roughly $281 million in a year, only a portion can move directly to providers for patient care payments. The rest must support broader transformation activities. That means rural hospital leaders should not assume RHTP will fill operating deficits, reserve long-term debt, or directly replace lost Medicaid revenue. Instead, RHTP is intended to create better systems, stronger local capacity, improved access, and more sustainable care models. All of that is obviously very important work, but it's different from unrestricted financial stabilization. The central tension is this. RHTP is transformational at the state level, but often thin at the individual hospital operating margin level. So having said that, what's it feel like inside a rural hospital? Well, let's make this more practical. And, I like to show examples, so here's another one. Imagine a 40-bed rural Texas hospital. It may be the only hospital within 50 or 60 miles. It provides emergency care, inpatient care, outpatient services, imaging, basic surgery, and stabilization before transfer when higher acuity services are needed. Its payer mix includes a large share of Medicare and Medicaid patients. It has a small IT team, perhaps one or two people, who are responsible for everything from cybersecurity and EHR support to vendor relationships and troubleshooting. The leadership team, they're busy. Here's what they're managing: recruitment and retention challenges, aging equipment, supply and drug costs, low volume service lines, emergency department demand, behavioral health gaps, payer denials, and rising expectations for quality reporting and data capabilities. Financially, the organization may be running near break-even or even in the red. It may have limited cash reserves, may already be in debt. It may have deferred facility upgrades for years because the hospital simply couldn't afford them. Now that organization hears about RHTP, what happens? Well, there's excitement, and there should be. But there are also immediate questions that relate to them. Will we qualify? Which Texas initiative fits our hospital? Do we have the staff to apply? Can we manage another reporting requirement? Will the funding pay for the project, or will it create costs we must carry later? What happens when the grant ends? That's a big one. Can we sustain the technology, staffing, or program after the RHTP dollars are gone? What do you think, right? All reasonable questions. A rural hospital does not have the luxury of taking on projects that are interesting but financially unsustainable. That's why the most effective RHTP projects will not simply be innovative. They will be financially logical. They will improve access, quality, workforce capacity, care coordination, or patient outcomes, while also helping the organization control cost, protect revenue, reduce and avoid utilization, or stabilize a strategically important service line. So they're doing 2 to 10 things at the same time, and that's per person, it seems like. So all of this starts to make sense. You see the problem, you see the environment, you see the challenge. But what does this mean for vendors? Because they're part of this ecosystem as well. So if you're a vendor serving rural hospitals in Texas, RHTP creates real opportunity. It does. But it also requires a different mindset, right? The wrong approach is, in quotes, there's a new grant money available. Let's sell our product as an RHTP project. The better approach is, in quotes, this hospital has a structural financial challenge. How can our solution create measurable value without creating another long-term burden? That distinction really matters. In speaking with vendors prior to this episode, that's where everybody is committed to land. How are we going to actually help the hospital while not creating more burden for them? Those are always the vendors that are successful. First, rural hospitals will focus on total cost of ownership. A hospital may be able to pay for implementation through grant, but leadership will immediately ask, what are the recurring subscription costs? What staffing does this require? What internal resources will be needed? Does this require new training, data integration, or IT support? What happens after the initial funding period? Does this produce savings, revenue protection, or outcomes we can measure? If you're a vendor, your offering cannot just be affordable on day one. It has to be sustainable in year 2, year 3, and beyond. Second, generic consulting will face more scrutiny. RHTP funding is designed around defined transformational goals, right? CMS identifies areas such as prevention, workforce, technology-enabled care, access to behavioral health, chronic disease management, and innovative models of care. A vague proposal that says strategic consulting will be harder to justify, and rightly so. Hospitals need vendors who can connect the dots between a defined rural health challenge, an RHTP-eligible solution, a practical implementation plan, measurable outcomes, and a long-term sustainability strategy. All important and all doable. Third, vendors must be prepared for smaller phased projects. Many rural hospitals cannot absorb complex enterprise-level deployments. They might need a smaller implementation scope, rural-specific pricing model, a pilot before committing to scale, clear project management support, shared services models, or partnerships with other hospitals and local organizations. The vendor who says, we can start small, prove value, and scale responsibly will often be more credible than the vendor who shows up with a large, expensive, all-for-nothing solution. Fourth, trust matters more than ever. Rural health leaders have seen funding cycles come and go. It's nothing new to them. They have seen vendors appear when grant dollars are announced and disappear when the funding runs out. The vendors who will stand out are the ones who understand the local operating reality. They will be honest about what their solutions can and cannot accomplish. They will not pretend a technology platform can solve Medicaid underpayments. They will not claim a short-term program can eliminate structural deficits, but they will show how their solution can reduce avoidable cost, improve care delivery, protect revenue, strengthen workforce capability, or help the hospital use limited resources more effectively. This is a much, much stronger value proposition. So let's talk about reframing a vendor strategy. How should vendors position themselves in this environment? Well, here are 4 practical considerations, again, if it makes sense to you. Number 1, lead with a structural challenge, not the grant. Do not begin with, we can help you spend RHTP funding. Begin with the actual issue facing the hospital. For example, we can help reduce avoidable transfers. We can help stabilize your chronic disease management efforts. We can help you expand access without adding full-time staff. We can help make better use of limited clinical capacity. We can help you measure the impact of an RHTP-funded initiative. RHTP should be the fuel for the project, not the entire story. Number 2, map your solution to RHTP priorities. I know we've said it before in this episode, and some of these things are redundant, but they're so critically important for the hospital, making sure everyone understands what they need and how that aligns with RHTP requirements, as well as vendors who are trying to help the hospital, not only selling them products, but selling them and providing them with solutions. So again, map your solution to the RHTP priorities. Vendors should explicitly connect their services or products to RHTP's permitted categories, including prevention and chronic disease management, technology-enabled care delivery, workforce development and retention, behavioral health access, community-based care models, innovative payment and delivery approaches. A strong proposal should clearly state, this is important, so if you're a vendor, write this down. Proposal should state the challenge being addressed, the RHTP category it aligns with, the target population, the expected outcomes, the implementation requirements, the data or metrics that will demonstrate success, and the sustainability plan after grant funding. If your proposal incorporates all of those components for the hospital as you're going through this process, you're also saving them time, them headaches, and all the things that go with the onboarding process. It's a function of clarity. They'll know where to start. Number 3, right size the offer. Create a version of your solution designed for rural settings. That might mean phased implementation. It could be more straightforward pricing, limited technology burden, shared service options, rural-specific onboarding, fewer custom requirements, and of course, clear deliverables and timelines. Rural hospitals do not necessarily need less sophisticated solutions. They need solutions that are realistic for their staffing, cash flow, and operational capacity. Number 4, be transparent about sustainability. Every RHTP-related proposal should answer one question: what happens after the funding period ends? Offer a practical plan. That might look a little bit like this: a lower cost maintenance model, a phased expansion plan, not all at once, a clear exit strategy, a path to self-funding through savings or revenue protection, or shared ownership across multiple facilities or community partners. That level of transparency creates trust, and trust is often the deciding factor in rural markets. So, as many of you know, we go through our own go-forward strategy during every single episode. So we don't just hand you a piece of paper. We help you understand what it's going to take to shift from awareness to action. So let's start with rural hospitals. What should rural hospitals and vendors do? Both of them. Again, only if this makes sense to you. But what should rural hospitals think about? 3 moves. First, build an RHTP-aligned project portfolio, not a one-off grant list. Identify 3 to 5 major priorities for your hospital or health system. These might include chronic disease management, again, workforce recruitment and retention, telehealth and virtual specialty access, behavioral health access, revenue cycle improvement, rural EMS and transfer coordination, data, cybersecurity or interoperability needs, service line redesign. Then ask, which of these priorities will most directly improve their financial stability, the hospital's financial stability? Access to care, will it help that? Or ability to serve the community? Which of these priorities will help that? Rank projects based on impact, feasibility, funding alignment, required internal resources, and long-term stability. Do not chase every available grant. Use RHTP to advance the priorities that matter most to the organization. Second, create a cross-functional RHTP team. This is critical and, frankly, is a good way to build camaraderie as you go through difficult times and build on the future. Doesn't have to be a large committee, but it should include representatives from finance, clinical leadership, operations, IT, and of course, executive leadership. The team's job is to evaluate opportunities through one simple filter. Will this project improve our ability to survive, serve, and grow after the grant dollars are gone? The question protects the hospital from pursuing projects that sound attractive but create future unfunded obligations. Third, require a sustainability plan, from every partner. Make this a standard requirement. Ask every vendor, consultant, or community partner, what is the full cost over 3 years? What staffing requirements will this create? What outcomes should we expect? What metrics will show whether it is working or not? What happens if RHTP dollars decrease, change, or end? Is there a lower cost model, a phased model, or an exit option that we can have a look at? It's not negativity. It's methodical. It's good business. It's common sense. And it is responsible stewardship. Now let's talk about vendors and 5 strategic shifts. First, make your message hospital-centered. Don't lead with your product category. Lead with a problem that the hospital leadership team already recognizes. For example, we help rural hospitals reduce avoidable costs and improve care coordination without adding unsustainable complexity. If that message is stronger than, we provide a technology platform that may qualify for RHTP funding. Second, bring fundable project designs. This is really important. Don't make the hospital start from a blank page. Bring a draft project framework that includes the problem statement, the RHTP alignment, goals and objectives, recommended metrics, timeline, staffing requirements, budget range, sustainability plan. This moves you from vendor to design partner. And remember, we're building trust concurrent to these things. Third, develop rural-specific tiers and consortium options. Well, a single rural hospital may not have the scale to support a major enterprise deployment, but multiple facilities together may be able to share, and that might be the answer. Things like analytics platforms, workforce tools, virtual specialty services, population health programs, training resources, data, and reporting capabilities. Consortium models can make the economics work better for everybody. Fourth, integrate reporting and measurement from day one. Hospitals will need to demonstrate impact. Your solution should help them report outcomes such as reduced avoidable emergency department utilization, lower transfer rates, better chronic disease follow-up, improved access to specialty care, workforce retention, reduced administrative burden, that's a big one, improved patient engagement, financial savings, or revenue protection. Actually, all of those are big. And if you are helping them manage all that and providing that to them, again, they feel like they found a partner, not just a vendor. So try your best not to treat measurement as an afterthought. Make it part of the value proposition and use it when you start the engagement. Fifth, also, this is a tough one, but be honest about the limits of your solution. Your solution may improve access, efficiency, workforce capacity, or patient outcomes, but it may not solve Medicaid underpayment, rural workforce shortages, debt, or the long-term structural deficit by itself. Just say that clearly. Then explain the specific measurable difference you can make. In rural healthcare, credibility often wins over hype. Also, something to consider is where life science logic might fit into this equation. We see the go-forward strategy as a 3-part process. First, understand the financial logic of the rural hospital. What's the payer mix? What are the biggest margin pressures? Which service lines are most vulnerable? Where is the growth, efficiency, and access opportunities? And what are the risks if funding changes? Second, overlay the RHTP logic. What will Texas fund? Which initiatives align with the hospital's needs? What partners are needed? What measurement and reporting requirements apply? And what is realistic given the hospital's capacity? Third, co-design a right-sized project portfolio. Fundable, measurable, operationally realistic, sustainable, and directly connected to the hospital's most important challenges. The goal is not to spend grant dollars. The goal is to use limited funding to build a stronger rural health system that can continue delivering care long after the initial RHTP investment is gone. So, in closing, let's bring this full circle. Rural hospitals in Texas face real and persistent pressures. Underpayment from Medicare and Medicaid, uncompensated care and bad debt, workforce shortages, aging facilities and technology, thin operating margins, limited reserves, debt, and ongoing closure risk. The Rural Health Transformation Program is a major opportunity. Texas is expected to receive approximately $81 million per year over 5 years. But RHTP dollars are not a cure for every underlying financial challenge. They are constrained, they are competitive, they are targeted, and they are temporary. For rural hospitals, the opportunity is to use RHTP as strategic leverage to invest in projects that protect access, reduce avoidable costs, strengthen workforce, modernize delivery care, and improve long-term sustainability. For vendors, the opportunity is to become a credible, practical partner. That means understanding the structural deficit. It means offering solutions that are right-sized, measurable, sustainable, and tied to the actual realities of rural healthcare. So, next week's episode, the Rural Care Front Door, why FQHCs and RHCs matter to the Texas RHTP. If you're a rural hospital leader, healthcare innovator, or vendor serving the rural Texas area and would like help translating RHTP funding into a practical growth strategy or implementation strategy, reach out to us at Life Science Logic. You can find the contact information in the show notes. By the way, speaking of show notes, for those who want to dig a little deeper, do check out our show notes. We make sure we have that after every episode so you know where we find the information in alignment with our own opinion. And as you might imagine, the resources for today's episode were extensive. Until next week, keep advancing with logic, purpose, and a clear path forward. Thanks for spending time with me today on Healthcare Logic for Growth. If this episode brought you value, share it with someone in your network who's navigating their own commercial journey. I think they'll appreciate it. And if you have a healthcare-related topic you want me to tackle, leave me a note at eric@lifesciencelogic.com. Thanks again. I hope you'll join me on the next episode.